Have you ever felt unheard by your doctor? Maybe you've been frustrated that they haven't understood your symptoms or that they have neglected your concerns. If that's you, then you're not alone. In her debut book, Dr Rageshri Dhairyawan, an HIV specialist with a research interest in health equity, describes what she calls the medical practice of silencing. Having experienced the NHS both as a doctor and a patient, Dhairyawan shares her unique perspective on a health system that produces outcomes that are not equal for all. She talks about how patients are dismissed and devalued, what happens when doctors aren't heard, and how the neglect of minoritized researchers creates a knowledge gap. She goes on to outline the transition from paternalistic medicine to one that's, at least on paper, objective and evidence-based, while also capturing past battles patients had to fight, with a particular emphasis on the HIV movements in the 80s. The book is also a guide to how we can bring justice to unheard patients and communities by listening ethically, ending with an optimistic take on positive changes that we can already observe today. If these topics sound interesting to you, then let me break them down for you one by one and share the aspects that I found most memorable. Factoring in that every 36 hours there are over 1 million contacts between patients and healthcare workers in the UK, it's hard to believe that all these interactions happen smoothly. As a pessimist, you would say that this offers 1 million opportunities for negative interactions, where things could go wrong. Surprisingly though, the vast majority of these interactions are actually positive, but still there are those cases where patients get dismissed. One such case is that of a 21-year-old patient who died in a London hospital from the complications of sickle cell disease. This patient was sent to the general ward in the hospital after presenting with a high temperature, dehydration and yellowing of his eyes. The patient's symptoms worsened, so he asked for oxygen, but it got denied by the nurses, and feeling so desperate, the patient then dialed 999 to ask for oxygen again, but couldn't get help since he was already in hospital where oxygen was available. It took 5 days until the patient was seen by a hematologist who recognized the sickle cell disease crisis and arranged for the appropriate treatment, which unfortunately came too late. Dr. Dhairyawan's book has lots of these examples where patients' opinions on what's best for them get ignored by healthcare staff, leading to dire consequences such as this one. It's shocking to think that your own voice may be ignored when you need medical attention the most. We all, you and I included, can experience such dismissal by physicians and healthcare workers, but the dangers are bigger for some than they are for others. For example, people of color, people who are older, and people who are poorer are all more likely to experience worse health outcomes. Put simply, healthcare is less safe for some people than it is for others. A lot of this can be explained through the social determinants of health, but there is reason to believe that many of these harms could be avoided if communication between patients and healthcare staff was improved. Dhairyawan describes 10 practical recommendations for what patients can do to improve the doctor-patient communication, giving patients a better chance to get heard. These include planning for the consultation, educating yourself on the condition, or bringing a friend with you, which are all things to keep in mind for your next doctor visits. For patient voices to get heard, it not only requires patients to be able to articulate their medical conditions appropriately, but it also requires doctors who actually listen to them. Most GPs in the UK have about 10 minutes per consultation with a patient. Unsurprisingly, this just isn't enough time. As healthcare systems around the world become busier and more resource constrained, the focus is increasingly on getting more productive with the little time that's available. To be able to quickly determine what's causing a patient to be ill, future doctors are taught frameworks to sift through irrelevant information patients may provide during a consultation, allowing them to recognize diagnostic patterns more easily. Medical students don't know these frameworks yet, which means that they will ask a patient more questions as everything is potentially relevant. This causes patients to think of medical students as good listeners, given that they're asking so many questions, which indicates an interest in their personal health. Ironically, this is only because medical students haven't learned yet how to be selective with their questioning, something that more experienced doctors are well aware of. Most of us will have had an experience waiting to see a doctor for many weeks or months, if not longer, only to then have a short appointment that feels rushed and unsatisfactory. This, among other things, causes patients to complain about their doctors, which is more common than you might think. According to a survey from the Medical Defense Union, 97% of GPs and 88% of hospital doctors have had at least one complaint from a patient. When the author got her first complaint, she first thought that it must have been a mix-up, but then later accepted that she wasn't the doctor that patient needed that day. This goes to show that even the best doctors receive criticism, which seems to be part of the job description. I believe that most doctors truly want to help and listen to their patients, but often the time and resources are just limited, leading to imperfect outcomes. Sometimes it's not even the time factor which makes patients feel devalued, but instead it's because doctors don't offer them the right treatments for their ailments. In England, patients whose symptoms can't be medically explained make up 15 to 30%, leaving doctors without a clear course of action to support their patients. This lack of options, paired with the constant exposure to human suffering, which most doctors witness daily, can lead to what's known as compassion fatigue. Compassion fatigue is characterized by mental, physical, and emotional exhaustion, resulting from caring for individuals enduring trauma or suffering, and it can be a precursor to burnout. Medical doctors who suffer from burnout are twice as likely to be involved in a patient safety accident, which highlights doctor well-being as a patient safety issue. Burnout is only one of the factors that makes doctors less likely to listen, which leaves room for improvement. Among her ideas to make doctors better listeners, one of Dhairyawan's arguments stood out to me the most. This argument focused on training medical students on non-ideal patients, much more akin to what physicians will experience in the real world. Now that we know the cases when doctors don't listen, let's answer the question of what happens when doctors aren't heard. The answer to this question is very simple. When doctors aren't heard, health outcomes are worse. In particular, health outcomes for certain populations are worse, who are less represented in the medical community, which creates health inequalities. Common examples of these inequalities in the UK feature statistics which show that black men are twice as likely to be diagnosed with prostate cancer, or that South Asian and black people are 3 to 5 times more likely to start kidney dialysis. Research indicates that these statistics can be partly explained by the lack of a diverse workforce. Think back to your past interactions you had with your doctors. Whether we realize it or not, seeing a doctor who looks like you and who has similar cultural background makes it more likely for you to open up to them. If you're a white male, then you've probably never had any issues with this. However, US study results estimate an astonishing 8% reduction in the gap in life expectancy between black and white men if there were more black doctors. This is a reminder that sometimes it's not about the quality of care, but about who delivers the care. Who delivers the care is important, as due to testimonial injustice, certain voices are heard louder than others, which introduces bias. The concept of testimonial injustice occurs when a speaker is unfairly discredited or not believed due to a prejudice on the part of the listener, causing a credibility deficit. It is probably best illustrated with an example from work that people can relate to. In a meeting, you make a point which you think is genius, but your point just gets ignored. Just a few minutes later, someone else, more senior than you, makes the same point again and gets the credit for it. Just because someone who has more authority than you made the point, it got heard. The same happens to marginalized patients and doctors who have it more difficult for their point to get heard. But hearing these minoritized voices is so important, especially those of minoritized doctors, as they are more likely to advocate for minoritized patients and diseases that predominantly affect them. There is no way to guarantee that all voices are heard appropriately. But one thing healthcare leaders can do when chairing meetings is to create a psychologically safe environment, allowing everyone to speak up and share their opinion. In the business world, this practice is used to counter the HIPPO phenomenon, which stands for highest paid person's opinion, as it is known to lead to biased decision-making. Another bias in the practice of medical silencing are the missing voices of minoritized researchers, which creates a knowledge gap. One of those knowledge gaps is the divide between research done in the global north and the south, with the latter often going unheard. Causes for this gap can be traced back to areas of imperialism and colonialism, which to this day affect many practices of global health. As expressed by Makdur Pai, who's a professor of epidemiology and global health in Montreal, global health is firmly centered on those with power and privilege and focused on their generosity and saviorism. What I found eye-opening during the read of the book was how the roots of global health can be traced back to the discipline of tropical medicine, which in turn was born during the 16th and 17th century, when European colonizers encountered diseases foreign to them. To protect European people and to make sure that native peoples were healthy enough to continue working for the benefit of the colonizers, certainly shed some dark light over the otherwise so helpful research domain, which eventually led to the creation of global health. Even long past the days of colonialism, we can still see the divide it created for global health research, favoring the global north and neglecting the global south. Nonetheless, there are ways in which minoritized researchers can be better heard. For example, by abolishing open access charges for global south authors, publication in multiple languages, and carefully choosing the locations for international conferences. Not only does medical evidence get neglected when it's missing, such as we've just seen in the case of research from the global south, but it can also be neglected based on the type of evidence itself. The type of evidence, or in better words, what we count as medical evidence, has drastically evolved over the past 35 years. It was not before the year 1991 that the term evidence-based medicine was coined, which really makes you think what kind of evidence medicine was based on before then. The truth is that the shift from paternalistic medicine, which was anchored in tradition, anecdotal evidence, and expert opinion, to a new form of medicine which relies on statistics and hard evidence collected in randomized controlled trials, happened not too long ago. Now people working in the medical profession know about the fundamentals of research design, the evidence hierarchy pyramid, and study quality frameworks like GRADE. Almost 200 years after Dr. Semmelweis pioneered hand hygiene in medical practice, dramatically reducing maternal deaths by advocating for hand washing, and with all the modern evidence assessment tools at our disposals, you would think that women giving birth now no longer need to fear dying from pregnancy-related conditions. While this is largely true for women living in the global north, Black and brown women in the global south still remain unheard until today, being more likely to die from pregnancy-related conditions. Apart from geographical factors, patients can also have worse health outcomes simply by being unlucky enough to be struck by an illness with low disease prestige. By the logic of the concept, some diseases are more prestigious than others, affecting the level of attention they receive and hence impacting patient outcomes. Depending on the type of disease, the type of patient, and the type of treatment, patients fall in either one of two buckets, whereby you don't want to be affected by a non-prestigious disease. Just as how not prestigious diseases often don't get the attention they deserve, so do qualitative studies of individual patients. I can understand why big journals like the BMJ are in favor of more objective quantitative studies, but it seems at least a little odd to completely ignore the accounts of individual patients, who, after all, are the only ones that live experiences of having the disease. Accepting lived experience as a valid and credible source of medical information is one of the ways in which better medical evidence can be produced, according to Dr. Rageshri Dhairyawan. Reading about the many ways in which patients and doctors get unheard can be distressing, but luckily the book also includes great examples of how patients have fought in the past to get heard. The HIV movement is one such example, where patients and activists demanded inclusion in research and policy decisions and used media and legal pressure to push for faster and better care. What makes the HIV context unique is who was initially affected by it. It really mattered that AIDS affected white middle-class gay men in the US and Europe who had a degree of political clout. Imagine for a second HIV had only affected people in the global south. Would we have had the same level of advancements in care for patients that we have today? Before you answer this, let me contrast this with the example of tuberculosis, which now remains most prevalent in the global south and still kills 1.6 million people a year globally. Having a loud and ideally socioeconomically powerful community behind a disease will help raise its voice. But this is not always the case, and so patients fight uphill battles, remaining unheard. While some fights like the HIV movement happen in the streets, others happen in the office. Nowadays, many companies already have or are planning to introduce their own equality, diversity, and inclusion policies, or EDI for short. Think for a moment of the people who tend to oversee the introduction of these policies, or who sit on the EDI committee. This may just be me, but it always seems to be someone with a presumed lived experience of marginalization. And importantly, it doesn't have to be that way. Just because someone fits the typical EDI stereotype doesn't have to mean that they should be the one looking after it. If they want to do it, sure, but keep in mind that these people also give up other job opportunities that may benefit them more than doing the EDI initiatives. In the worst case, this leads to epistemic exploitation, which happens when someone from a marginalized group is expected to explain their experiences of oppression or injustice, often for the benefit of someone in a more privileged position, without being properly supported, acknowledged, or compensated. Another aspect of listening ethically is that we should make an effort to listen to the voices who are not in the room. Every time we hear someone from a marginalized community speak, that person holds some level of privilege, given that they're already in the room and in a position where they can talk about what's affecting them. This is known as elite capture, and it acts as a reminder to pass the mic to those not in the room. Despite the tough subject, Unheard ends with a positive conclusion, highlighting the good changes that have been made in the past to rehumanize healthcare. One of these changes is Martha's Rule, which now gives patients and their loved ones a right to a second senior medical opinion. In that way, the tragic death of Martha Mills, a 13-year-old child who died of sepsis despite her parents raising this as a concern, has now changed things for the better and will help save lives in the future. I've read this book from the perspective of a white European male who's got all the privilege in the world, and yet I found this book eye-opening as it pointed out so many of my own blind spots. If you at all can relate to any of what I've discussed in this video, I highly recommend you read Unheard yourself. But before you go out and buy her book though, go watch one of my other videos which you can see on screen right now.